Posterior labrum repair, two-portal technique. We have no disclosures related to this topic. Posterior labral injuries can cause shoulder pain and instability. They can be reliably repaired with arthroscopic surgery. We will outline an injury and workup involving a college football lineman who underwent a posterior labral repair. Case presentation: a 20-year-old male college football offensive lineman sustained an acute traumatic event while blocking during a game and felt his left shoulder dislocate and spontaneously reduce. MRI arthrogram demonstrated tear of the posterior labrum from the 1 o'clock to 6 o'clock position. The preoperative evaluation includes imaging. Shoulder radiographs are routinely obtained and include AP, scapular Y, and axillary views. MRI arthrogram can be helpful in subacute or chronic cases. Implants: we prefer knotless anchors to prevent rubbing of knots in articular cartilage and other intra-articular structures. Patient positioning: lateral decubitous position is used. The arm is held in suspension at approximately 20 degrees of forward flexion and 45 degrees of abduction. 10 to 15 pounds of traction is typically used. A spinal needle is placed into the glenohumeral joint at the proposed posterior portal site, and the joint is insufflated with 60 mL of arthroscopic fluid. A posterior portal is made and a 5.0 millimeter cannula is inserted into the joint. An anterior portal is established under direct visualization after the localization with the spinal needle. Once we've established our posterior portal, we'll establish our anterior portal. We establish this portal just above the subscapularis tendon. Oftentimes with these posterior labral tears, the tear can extend anteriorly, so you need a portal anteriorly where you could address the anterior labrum as well. Then we're going to place the scope back in the anterior portal and visualize the tear. This was an extensive tear involving the entire posterior labrum. Using a shaver and burr, we're going to prepare the glenoid rim to bleeding bone to stimulate a repair response. Next, we're going to bring in a working cannula. This particular cannula has wings that deploy that keep it from pulling out of the shoulder joint while you're working, an improvement over screw-in cannulas, which tend to fall out of the joint frequently. Next, we'll bring in a rasp and rasp the soft tissues to stimulate a healing response. We're going to bring a drill guide down to the 530 position. It's important that this is on the face of the glenoid and not medial on the glenoid. We're going to drill all of our holes first. We find this to be most efficient and minimizes the need for multiple instrument passes. We like to place as many anchors as possible. We feel that this ensures the success of the procedure as it does with anterior labral repairs. These holes are drilled as close as possible to each other without compromising the previous one. In this football player, we're going to place a total of 5 anchors posteriorly. Having your portal positioned correctly to get the correct trajectory is very important. Next, we'll bring in the small ablator to clear the soft tissue from the drill holes. This will enable us to identify these holes when it's time for anchor placement. A curved suture passer is then used to take a bite of capsule inferiorly. We're going to shift it superiorly and then come out underneath the labrum. We're going to shuttle the wire in to the joint, remove our suture passer, and then grab the wire with a looped grasping device. The suture is then loaded into the loop of this wire and pulled back through the soft tissues. The anchor is loaded with the suture, tension is placed, and the anchor is deployed. The handle is unscrewed from the anchor and removed. The suture is cut as flush as possible so that we don't have a tag of suture which can rub against the articular cartilage. Here we're visualizing the technique from outside of the shoulder. We're going to shuttle in as much of this wire as possible into the joint and then continue to deploy it when we pull out the instrument. My assistant has the free end of the wire in one hand. We'll reach in and grab the other end of the wire with the other hand. We're going to load the suture into the loop in the wire, placing 7 or 8 inches of the suture into the loop, and then it's pulled through the soft tissue. We then load the anchor with the suture. I deploy this anchors with two hands. I have an assistant hold the scope. I take out the slack of the suture with one hand. I'm placing tension on the suture. With the other hand, I'm controlling the driver. The assistant mallets the anchor into place. Appropriate tension on the suture is critical as you deploy the anchor to get a good solid labral repair. When we grab capsule, we try to grab a little bit inferior to our drill hole and shift superiorly to decrease inferior capsule volume and ensure success of the procedure. Or two-portal technique does not create twists or loops in the suture as long as this technique is followed. One tip when using the suture passer, we'll go through capsule, aim towards the labrum. Typically, I'll hit the glenoid bone and walk it up until I hit the transition to the labrum, and then sneak the wire underneath the labrum. As you can see, multiple anchors can be placed quickly and efficiently using this two-portal technique. As we get to the superiormost anchor, sometimes we'll switch to a 90-degree passer, which gives us a little better trajectory. Again, we'll shuttle in as much wire as we can, pull out the instrument. The assistant holds the free end of the wire that's out of the joint. We'll reach in with this loop grasper, grab the wire, and pull the loop end out so that it can be loaded with suture. Again, this does not result in tangling of the suture when done appropriately. So we've placed 5 anchors in this football player, repaired the labrum, tightened the capsule to prevent future instability episodes. For instability cases, I don't like using this posterior capsulotomy, so we're going to close it. We'll bring in a corkscrew cannula. I'm going to take a suture and load it into a 45-degree bird beak type passing device. We'll unscrew the cannula till it's just outside of the capsule. We'll bring in our suture device loaded with suture, pass it through the capsule inferiorly. We're going to advance the suture as far into the joint as we can, and then try to pull the instrument out without pulling our suture out. We'll then go through the capsule superiorly, grab the loop of suture, and pull it out of our cannula. Now we have both limbs of suture out of the cannula. We're going to tie a sliding locking knot. This is a Weston knot. We're going to tie this knot blind. We'll push the knot down. One assistant holds the cannula, push the knot down and flip it, and then place subsequent half hitches to secure the knot. This suture cutter slides down to the knot and allows you to cut blind, leaving a 2 to 3 millimeter tag. And this is the completed capsulolabral repair with posterior portal.
Clinical pearls. In terms of portal placement, we used a posterior portal that can be used for visualization and as a working portal. It is positioned midway between the standard posterior portal and previously described 7 o'clock portal. It is located approximately 2 centimeters anterolateral to the posterolateral corner of the acromion. Our anterior portal is located 1 to 2 centimeters lateral to the coracoid. The cannula is brought in through the rotator interval just adjacent to the subscapularis tendon. In terms of labrum visualization and preparation, we prefer a posterior cannula which has deployable wings. This style of cannula will remain in position and in the joint throughout the entire procedure. Typical corkscrew cannulas constantly back out of the capsule and joint, which can be a source of frustration. In terms of preparation, unlike anterior Bankart tears, which are often scarred medially to the glenoid, posterior labral tears are often non-displaced. If there is medial scarring to the glenoid, then a small elevator can be used through the posterior portal to free it and make it more mobile. Clinical pearls. In terms of anchor placement, we drill all the holes for the anchors before placing the first anchor. We find this to be most efficient and eliminates the need for multiple instrument passes. Potential complications. There can be direct injury to axillary, musculocutaneous, and suprascapular nerves through accessory portal placement or errant intra-articular instrumentation. Recurrent instability or failure has been reported in 3.5 to 8.1% with arthroscopic repair. Return to sports, general guidelines, sling for 6 weeks except with showering or when working with physical therapy. Discharge testing is done anywhere from 6 to 12 months postoperatively. The patient needs to demonstrate quality and symmetrical movement throughout the body. There are 3 phases to our physical therapy protocol. The maximum protection phase is from 0 to 6 weeks. The moderate protection phase is 7 to 12 weeks. The minimal protection phase is from 13 to 24 weeks, where we progress to full passive range of motion and active range of motion. And finally, we'll progress the patient into an interval sports program. In terms of patient outcomes, Bradley et al. In a large series of 200 patients reported 90% return to sports. In a systematic review by DeLong et al., they found improved return to play and lower recurrence rates with arthroscopic repairs as opposed to open repair. Ostrander et al. Reported on 56 football players who underwent arthroscopic posterior stabilization and showed improved ASES scores, 93% return to sports, 79% at a pre-injury level, and a 3.5% failure rate.